Hi, and welcome again to a new episode of our webinar, Collaboration Beyond Disciplinary Boundaries, How to Make It Work. It is a webinar series focusing on identifying some barriers and solutions to genuine interdisciplinary in research and education, interdisciplinarity, in research and education. And today we have the pleasure to have with us Andrew Eccles from the School of Social Work and Social Policy in University of Strathclyde in Scotland. And I hope I said it right, Andrew?
Yeah.
Okay, now I can give you the word.
That's good. I'm going to screen share. This is the one I want to use. I'm going to go there. Okay, I'm happy to take over from here. So what I've got here is the title, Working Across Disciplines, Embrace the Pain, which is a slightly cheeky take on the idea that we absolutely have to work across disciplines. And I think we're going to discover in the course of the talk just why, but also it's not going to be straightforward. And despite the wishes of policymakers often that we simply collaborate, collaboration often is quite complex and quite difficult. Nonetheless, I think we have to do it. Hence the nature of the title, Embrace the Pain. So I've been working with organizations in particular for about the past 20 years on collaborative working, especially between health and social care. And then I have also have an interest in care technologies, health and care technologies, and the ways in which research collaborates on these areas. So what I want to do is have three areas of focus today. I'm going to talk inter alia about tensions across research traditions, but I can't imagine that's going to be greatly novel in the sense that there's a lot been written about this over the years. So questions of epistemic tensions across different research approaches, but I will touch on that a little bit. I do want to spend a little bit more time on the politics of research and of inconvenient findings, because what I'm going to suggest is that sometimes the different disciplines that collaborate may arrive at different conclusions, and these may indeed be, I'll use the phrase advisedly, cherry-picked for ways in which they may or may not be useful to the politics of any situation. I think COVID is a fascinating example at the moment in the United Kingdom, where we have a great deal of evidence which appears to be ignored because of politics is developing in a somewhat different direction from the evidence base. So it's a very topical issue, and I am going to develop the politics a little bit more than I might have originally, simply because I think the COVID thing is bringing this to light at the moment. And finally, I'm currently involved I'm the social scientist in a multidisciplinary health technologies project across 5 UK universities. And we've been funded to go and look at the development of health technologies and the self-management of care. And I want to spend some time looking at that particular project, which is in its early stages, but how did we get the award in the first place? What did it take? And how are we now going to develop this? So the first thing I want to do is to talk a little bit about multidisciplinary working in other contexts. So what I'm going to do here is think about a way into thinking about multidisciplinary research by thinking about, well, what do we know about the real world working across disciplines in other areas? And there is a long running saga of getting health and social care to work across their professional boundaries, for which we have very rich data from multiple studies. And this goes back the last 20 years. Now, I'm not going to dwell on this, but I am going to start looking at what we understand about when we take different professional disciplines, health, social care, different aspects of health between acute and primary medicine, and we try and get them to work together. And then I'm going to draw some ways of thinking about that into the subject under discussion today, which is about multidisciplinary research. So I'm going to condense about 20 years of research, a lot of which I was involved with by doing primary research myself, a lead researcher 20 years ago, with various organizations, especially in health. And I want to know what 20 years of research can actually tell us about working across disciplines in human services. And then I'm going to think there may be some aspects of that which will be useful to us in terms of how we can then maybe translate that, even if loosely, into the idea of interdisciplinary research working. The first thing that has struck me about 20 years of research, and it's not just me, there's a great deal of research now been done, is the prevalence of, but avoidance in considering what we call wicked issues. And I think wicked issues emerge also in cross-disciplinary research. What we mean by wicked issues are complex areas that don't have any standardized approaches or standardized solutions, or indeed can reasonably be replicated. And these often appear in social contexts. For example, some of the work that I've been looking at is in quite complex social interventions involving social work in particular. And it's pretty safe to say that the particular circumstances of one intervention with one family, for example, will not be replicated easily in other circumstances. So we have these complex, wicked issues with multiple inputs into why they might be problematic in the first place, but no obvious sense in which will always be replicated. And I think that's a useful way of thinking about the idea of how these are often avoided when we start to think about interprofessional working across disciplines. We have a strong desire of policymakers to lean towards prescriptive, what I'll call top-down solutions to problems. Again, I think we're going to come and find some resonance here, which is that policymakers would like things to happen and effectively are very prescriptive in terms of what it is they want, but they leave the complexity of this to people on the front line. We have a strong prevalence of linear thinking, which ignores social complexity. And by linear, I simply mean a sense in which there is an obvious connection between different stages of policy development. I often see this when I look at flow charts, and I give a gasp of minor despair when I see about 50 different boxes, and I'm thinking you're ignoring the complexity here because A does not necessarily lead to B if you're dealing, for example, with particularly troubled families whose circumstances are difficult to be able to resolve. There was, and we have again a great deal of evidence of this, of lack of work in developing trust across disciplines, which is absolutely crucial. There was a lack of sustained work in developing cross-disciplinary understandings of each other's discipline. In other words, much of this work has simply been very top-down driven, saying just you on the front line make this work. There's also a lack of clarity in what was being sought. Are we looking for cross-disciplinary working? Are we looking for greater generic working? It's not clear. The absence of any discussion around power differentials across disciplines. So, for example, social care is a relatively powerless, relatively, to medicine and health, which are much longer established and more powerful. But we don't have this discussion. We talk instead of partnerships, but it's not an equal partnership. And therefore, again, there's a power differential to consider. There's an absence of many meaningful discussion around tensions in values and ethics. And basically, the research experience suggests that actually working across organizations is complex and difficult. Much of this was attempted in the United Kingdom about 20 years ago, and much of it didn't come to fruition because of the complexity. And yet, for example, in Scotland in 2014, legislation was introduced which mandated that health and social care would now integrate. And that's a remarkable development, because if you think that integration would be the end of a long, complex process, then how do you arrive at that decision? Where was the groundwork which led to this? So in fact, what's been happening is a process-driven way of trying to get organizations to work together rather than understanding issues of complexity and trust. And my own research experience in this has been quite interesting over the years. I spent 3 years doing research around the development of multidisciplinary teams, but also tools whereby organizations could work together across boundaries. I think one of these documents emerged to a 108-page document based on about 70 interviews with frontline staff. And at the presentation of this to the Directorate of Health and Social Work, it was pretty obvious there were some inconvenient truths emerging. And therefore, basically, the issue got reframed by the policymakers sitting in the room. One of them objected to the report and said, well, it's all very well, all these problems that you're raising, but we are now integrated, which I have to say was astonishing given the evidence that we produced after 70 interviews, which suggested anything but. And also very simplistic demands. For example, a very senior manager saying, well, it's a 108-page report. Could you put it onto one A4 sheet for us, please? And I would say, well, the whole point of this is it's complex. So no, I can't. One of the other things that emerges from this, which I think is relevant again to the idea of interdisciplinary working when it comes to research, is the work of the French sociologist Pierre Bourdieu. and his notion of habitus. And I'm going to do a quote from something I wrote almost a decade now ago, when I was thinking about how organizations work together. It's not necessarily that professions are unwilling to engage with others. It is the sense they make of a given situation will be constrained by their unconscious understanding of the world, developed through their history and practice. This is why the attempt to cross disciplinary barriers is not a straightforward quick fix task. And equally, this is why process and organizationally driven reform are unlikely to succeed in crossing these more deeply embedded discipline-based divides. 2 years after that, the Scottish Government proceeded, despite the fact I gave evidence at the stage of forming the legislation in the parliamentary committees, and went ahead basically with a very top-down process of integration, to which you think, this is really interesting. There's something powerful here about the unwillingness to engage with complexity. A couple of very minor points in this, which I want to think about. If we have organizations coming together, in this case, I'm still talking about medicine and health and social care, do individual professions compromise too much, for example, in their value bases or their ethical outlooks, in order to accommodate a desire for consensus and agreement? This may also have some relevance when it comes to thinking about multidisciplinary research and working across teams, because there are power dynamics and often forms of unobservable power. Who sets the agenda for any given meeting, for example? The sheer weight of fiscal weight, for example, of medicine and health vis-a-vis, for example, social care, but also public attitudes. If you ask the public what they would like their taxes spent on, they're much more likely to alight on the idea of healthcare than the idea of helping out people who are living in more marginalized circumstances. That's quite clear. And finally, in this kind of vein of thinking about this, much of the way in which we set up evaluating organizations is based on a set of performance criteria. Universities are strongly based, for example, in the United Kingdom on league tables for teaching, for research. And yet what we're also asking at the same time is for organizations increasingly to collaborate. So here's a very simple, to the point of being simplistic way of looking at it, which is that individually universities and other research organizations will have performance criteria to hit. So it doesn't make it easy to collaborate when we're all still stuck in this performance regime thinking. And that certainly applies to organizations in the real world out there, like in medicine and health and social care. Unless you have agreed collaborative outcomes, and the performance criteria will become problematic. So I want to finish this first section by just summing up an argument here about the different characteristics of agencies which attempt multidisciplinary working. And then I'm going to transfer some of that observation from 20 years of working with organizations that are attempting to do this into the idea of multidisciplinary working in terms of research. So for example, we start here on the left-hand side with the policy. The policy is we would like all you organizations to work together. So the different circles might represent housing or health or social care or the police or various other organizations, all of which will have some bearing in some of the complex issues that are being dealt with on the front line. And then we hope that basically they'll all collaborate and we'll have better implementation. And here we can see on the vertical set of issues here, we've got issues around professional values, which will be different. We've got different forms of accountability. We've got different structures of governance. We've got different organizational power, which I've been talking about already, but we've got different financial power. And again, we have this idea of Bourdieu's habitus, the cultural aspects of work, the way we are deeply embedded in the type of work we do, which might make it difficult for us to come out and cross boundaries. Now, that suggests that there is a wealth of research out there on the real world working of trying to get agencies to work in a more multidisciplinary way. And it suggests that the byword here is complexity. And if you ignore the complexity, it's unlikely to be successful. So I want to take this same diagram effectively, and I want to think about the different characteristics of disciplines which attempt multidisciplinary research. So I'm doing the same thing here. I've basically, on the left-hand side, I've taken the research question and then basically said, here we have all these different disciplines, and then basically to move towards an implementation, which might be a research strategy, for example, or some agreed form of solution to a particular research question. And here I have on the vertical axis again, I've got different ways in which this might prove problematic. First, there are different epistemological positions, there are epistemic tensions across different research disciplines. I'm sure this is very familiar to anyone that's been looking at anything to do with multidisciplinary research, but I'll touch on this in a minute. We then have, in some ways, a more problematic issue, which is the acceptance of different methodologies. Indeed, some people would argue there are no methodologies, there is only a methodology. And if there isn't a randomized controlled trial sitting in there somewhere, it's not really research. So that takes us into some complexity immediately. And then following on from that, we need to be a high level of trust and confidence in the methods and not least the data analysis that's being pursued by the different disciplines involved in this. I've told this small story before, but being involved some years ago in a large multidisciplinary research project, I offered to give a social science analysis of a health technology intervention, at which point the chair of the meeting said, this will be like an afternoon on magic mushrooms, which in itself is amusing, but also betrays a kind of lack of understanding of what social science might bring to the table. And to which I had to respond, it will be nowhere near as much fun. We also have questions around validity, because social scientists don't tend to talk about validity in the same terms. So for example, we're interested certainly in rigor and trustworthiness, but validity doesn't necessarily match up in the same way that it might from the hard sciences. I think also there are other tensions across a willingness to accept political policy framing. And I'll come on to discuss what I mean by that. But I think this has become evident in the current project that I'm working in. And that's often quite unconscious, but it may be that some of the engineers, for example, that I'm working with are more readily tuned in to the policy proposals of governments in terms, for example, of the use of exciting, shiny new technologies in future. And some of the social scientists might be asking about some of the complexities of this in a more socio-technical way. So the policy framing becomes an important issue on the extent to which different multidisciplinary partners might become engaged. There is, of course, enormous differences in financial power held by the different disciplines. This becomes very evident. Social scientists usually celebrate grants coming their way that I suspect some people in the biosciences and the world of medicine might not be getting out of bed for in the morning for those amounts of money. So we have differentials of power in that sense, effectively. Again, that might be unconscious, but it's certainly there. And then finally, we have, of course, what happens to the inconvenient truths, especially those that are thrown up by social science inquiry. And we're certainly seeing this at the moment with COVID-19 in the UK, where there is now a raft of information, especially from public health and epidemiologists, and simply the policy response to that, certainly in England at the moment, stretches credibility and in some cases with some very good colleagues of mine, simply defies belief. So these inconvenient truths come up against the political reality of how problems intend to get solved. So I'm really not going to dwell a lot on epistemological positions, but I will, just for the sake of saying we can understand some of the more problematic issues that might arise across multidisciplinary research. But this is fairly standard stuff from a multitude of different textbooks that you can alight on for looking at questions of epistemic tensions. We have, again, this assumption in a more positivist approach, the one favored by the hard sciences. There's assumptions around objective knowledge. There is a knowable world, which is objective, and it's up to us to discover it. Separates out facts from values, largely based on quantitative data, strict rules, procedures, the use, for example, of randomized control trials, and a search for generalizability and replicability. And neither of those phrases, generalizability nor replicability, would readily come to mind in social science research, although interestingly, they're starting to pop up more and more often about attempts to try and go in that direction, which suggests, again, a kind of hard sciences imperialism at work in terms of what we regard as rigorous inquiry. It also, of course, assumes the possibility, drawing on the point I'm just making, to transfer these methods of the natural sciences to social sciences. And we're going to discover in the exercise in there at the moment that some of the discussions around different teams that were looking to get some of the funding had a very strong sense of that idea of how the social sciences have to start adopting some of the methods of natural sciences, but they don't sit easily together. Now, a more interpretivist approach, one that would tend to emerge much more in the social sciences, we would say positivist accounts ought not necessarily to be accorded a privileged position. They are one account amongst others, and we have to let those others have the space to breathe and also in some trying way be influential. Knowledge is also, of course, a social and historical product. Facts can be theory-laden and not simply objectively out there waiting to be discovered. We make meaning, basically, ourselves in terms of the way that we view the world and also just the way that we conduct research. The real world is complex and can be viewed from different perspectives. The role of language and meaning is important, hence the use of qualitative methods. For example, extended interviews with a great deal of data in them, in which we can start to unpack the meaning of people that we're engaging with, their use of language, which is often not at all technical. And we have to understand the world in terms of their meaning making within that world. I'd finally say interpretivist approaches can be highly emancipatory for participants. And I've interviewed many both frontline workers, but also service users over the years. And it's quite remarkable about how that space to be able to talk, for example, about how their work processes are impacting on them, or how some of the technologies which are regarded by technologists as useful and shiny and new and will improve people's lives actually prove very difficult. And we can do this in a language that can be understood and interpreted by a good social science researcher. And in that sense, they can be highly emancipatory for participants in a way, for example, that a simple survey can't. We need to get into some of the complexity here. So I've used this particular slide because it came out from an organization which I hadn't prior heard to, called the Global Wellness Institute, and it cautions industry and consumers to sift fact from fiction when it comes to immunity boosting claims for coronavirus. So I pulled it in here, not least because it's nice and colorful, but it's also incredibly topical. And what was happening here was that this institute was basically saying we need to be very careful in understanding the nature of claims around coronavirus. And what it does is it replicates basically the fairly standard, almost to the point of being a trope, idea of a hierarchy of evidence, the systematic reviews, the meta-analysis, the Cochrane collaboration at the top, randomized controlled trials, quasi-experimental, and then we've got non-randomized observational trials, and then basically case studies, surveys, anecdotes. And there we are, right rooted at the bottom of the hierarchy, qualitative research. Now, what fascinates me about this particular hierarchy of evidence is not the fact that I haven't seen it 1,000 times before, and the idea that it prioritizes and gives an enormous sense of credence to systematic reviews and randomized control trials, and it puts qualitative firmly at the bottom in terms of, as the organization has said, strong evidence. But actually, in the early days of coronavirus, the single most important understanding of what was going on were anecdotes. Because we didn't have any randomized controlled trials in the early stage. And the biggest single anecdote that was coming out, certainly from colleagues that I'm working with, both in medicine and also across the social scientists, was that basically if you're in a crowded room, there's a higher propensity for people to end up going down with COVID-19. And there was a very early study which was done on choir singing and the astonishing impact of the number of people who were singing in a choir that contacted COVID within 3 days later. That's an anecdote. It's also extremely important. And what it meant was that by March of 2020, masks became a very powerful tool to be able to understand the ways in which we might be able to combat the spread of COVID-19, even though we hadn't actually done the trials yet, but we had the anecdotal evidence which allows us to say, if we mask up, we may be able to contain this. And yet, of course, that was based on anecdotes, but the anecdotes were extremely powerful at that point. Subsequent to this, of course, masking wasn't taken up until later, and still, even certainly within England, the chief medical officer took a long time to come around to the idea that this was in some way powerful or important. So we have some tensions about validity and the adoption of research. We have a suspicion of basically research that's not using randomized control trials. And I've certainly encountered this over the years. I've been told I'm not actually doing research because I can't be, because I'm not using an RCT. What I'm doing is something, but they're not quite sure what. And this reaches out to this question of validity, which is people coming from a more hard sciences tradition, I think, find the idea of non-RCT based research lacking in validity because they're very much trained in that tradition. But of course, we have the limitations of RCTs in addressing research. And I'll come to this on a separate slide in a minute, because most of the questions that I want to ask as a social scientist simply cannot be answered by a randomized control trial. And therefore, my obvious question always to colleagues who are using randomized control trials is, how would you do it in that case? And there I hit a bit of a blank wall, because they say, well, we're not happy with the methods you're using. And I say, well, does that mean the question's not valid? Oh, the question's valid, but you've got to use these more rigorous techniques. It becomes a kind of circuitous argument. Research methods for different audiences. We have to think about how we engage with each other's interests. And I'm going to come to that as well, because certainly policymakers like to engage with the processes that are often used within the hard sciences. And I think policymakers sometimes struggle with the results of more qualitative research from the social sciences, not least because it tends to throw up inconvenient positions from time to time. Then we can ask basically which research is better funded. That's almost a no-brainer of a question. It tends to be the hard sciences. Which research is adopted more and why by policymakers? Is this not also to the detriment of policy implementation? And I'm going to come to this. So what we've discovered, because I'm going to move on to talking about technologies in use in health and social care, which is a project I'm involved with the different universities at the moment. What we discovered early on was the sidelining effectively of social science inquiry, of a more qualitative inquiry on user experiences. And we moved ahead with a randomized control trial. And yet, 10 years ago, some of us were arguing, but the randomized control trial is not actually going to tell you what you want here. You have to understand the user experience to be able to know if this is going to work, because it might work in the minds of technologists, but if people are not actually going to engage with the technology, there's really no point in producing it. So Angus Deaton and Cartwright, basically in a paper, Understanding and Misunderstanding Randomized Controlled Trials, it's a nice paper in Social Science and Medicine, say randomized controlled trials can play a role in building scientific knowledge and useful predictions, but they can only do so as part of a cumulative program, combining with other methods, including conceptual and theoretical development, to discover not what works, but why things work. And to that, I would extend why things may or may not be adopted, even though they appear in a theoretical sense to be obvious that they would. And we'll come to this when we start to talk about health technologies. So it seems to me there's something of a threat to the social sciences in recent years, the shift of social sciences towards emulating the hard sciences. For example, the turn towards evidence-based practice in areas of social complexity, when basically evidence-based practice isn't actually going to tell you a huge amount. I've supervised some nice student dissertations which are asking social workers about their use of evidence-based practice, to which social workers would say, well, it's not as if I ignore it, but I use wisdom and knowledge and cumulative discussion amongst my colleagues, and not always simply based on that kind of very strong medical approach of evidence-based practice. Sometimes it takes wisdom as well as evidence. So if we look at US sociology, the last time I looked at the figures, 70% of all papers published in the United States in the field of sociology had a quantitative focus. That 70% were using quants. And again, it's that push to replicate the hard sciences, a form of what I said before, a kind of hard science imperialism, which says this is the way you do research. But social sciences are asking different questions to find out different things. And so the approach of the hard sciences simply is not appropriate, nor would it work for that matter. And then we have a further question, which Frank Fisher asks rather brilliantly in Democracy and Expertise, which is who decides the parameters whereby the public can challenge expertise? And again, we have that framing of the nature of the discussion, which is often generated by experts. So when I talk to colleagues, for example, that work in biomedicine in the university I'm working in biomedical engineering, and we talk about co-production, I'm coming at it from the angle of a social scientist, which is we really deeply engage service users in shaping and fashioning their own lives. And their response to what co-production would be, well, it's about asking people some questions. It's about forming a survey. That's a very different understanding of what appears to be a very similar phrase here. Okay, I now want to move on to some comment on the politics of research. And this seems to me something that's worth thinking about with a little bit of depth, not least because it's coming up so much under the circumstances of COVID-19 in the United Kingdom at the moment, which is, it appears that the politics of decision-making are flying in the face of the available research evidence. And yet politicians are, especially in England, I have to say, because there are different systems, are consistently saying they're following the science. That's true up to a point, but they're following a particular type of science, and that particular type of science is not often accepted by others within the scientific community. So a couple of quotes to start from Antigone, Sophocles: "To reject good counsel is a crime." We might want to bear that at the moment. And attributed to George Orwell, but I've read a lot of Orwell and never come across it: "In a time of universal deceit, telling the truth is a revolutionary act." And it may be we're engaging in some revolutionary acts around this question of COVID at the moment in terms of calling out the direction of the political decision-making. So Frank Fisher's other work included a wonderful text called Reframing Public Policy, Discursive Politics and Deliberative Practices back in 2003. And Fisher talks about evidence and what he calls performative politics. Actually, that's from the 2010 book. Not just a question of how data is obtained, but how it gets used, the questions it frames, the agendas it supports. And I think when we're going to start talking about multidisciplinary working, we have to bring some politics into this in terms of what is the objective of the multidisciplinary research and whose agenda is it fitting into in terms of either the funders or the end product in terms of how it reaches some policy objectives. And to this end, I want to talk a little bit briefly about policy frames. And the way that policy is framed by policymakers. In other words, the way it delimits the idea of what we can discuss. So what's available in terms of the nature of the discussion comes from the top down. And it may also impact, of course, on funding as well. Not all research is equally well received at values, and some, not least critical social science inquiry, may get sidelined unless it fits a policy frame fashioned by policymakers. I'm going to give you an example of one in the next slide. Policymakers want policy solutions or justifications for non-solutions, and policy is framed in ways that preclude certain types of argument and evidence. So I think if we're going to talk about multidisciplinary research, we have to think about the wider picture in which that multidisciplinary research sits, which is it may well contribute to a profound understanding of the nature of a research problem and some solutions. But the solution is going to be taken up only if it fits, in many cases, within a framing of policy solutions by policymakers themselves. And that is, in essence, a political act. Here's a quote actually from Julia Lynch, her book Regimes of Inequality, The Political Economy of Health and Wealth. I think it's one of the most profound books in social science that's come out in recent years. I'm going to just skip through this basically quickly. It's a quote from the author herself. "When center-left politicians take up the issue of socioeconomic inequalities in health, they do so in response to perceived taboos against redistribution, public spending and market regulation in the neoliberal era. Reframing inequality as a matter of health rather than of the maldistribution of political and economic resources is at best a partial solution. It reshapes the policymaking environment surrounding social inequality in ways that make it more difficult to reduce either socioeconomic inequality or health inequalities. Technocratic, medicalized inequality discourses result in shifting the Overton window. The Overton window is basically what's regarded as acceptable discussion in public discourse around inequality away from tried and true policy remedies for inequality and towards complex policy levers that are far more likely to fail. It's actually a cross-national study she was doing with policymakers and the extent to which we can no longer get the idea of redistributive politics on the agenda, and instead we reframe it in terms of health inequalities. That's where the money goes, that's what people are working on. But as she points out, that actually may be counterproductive in terms of actually doing something about health inequality, social inequality itself. Now, here's a graph which I don't expect anyone, it's actually a histogram, that anyone to be able to unpack immediately. It's a very profound piece of work by David Nutt and others, which was in the Lancet. I've given you a reference here. It was called Drug Harms in the UK, a multi-criteria decision analysis. Very powerful piece of work based on many years of research. And what Nutt did basically was to look at all the different possible types of harm. And these are listed basically on the vertical there in terms of the different key boxes. And basically then looked at drugs and said, well, which drugs are the most harmful if you take in not only the harms to the individual, but the wider social harms that might impact. And he came up with the fact that he thought the most harmful drug was alcohol, followed by heroin, crack cocaine, and then basically cocaine itself, tobacco sitting high up. And then basically we go right down to the bottom and we come into mushrooms, the celebrated ones that one of my colleagues thought it would be like having one of my research papers. And then we have LSD, ecstasy, and so on and so forth. And this is a very interesting piece of work. It was published in the Lancet. It obviously raised some counter arguments as well, which is if we legalized all these drugs, do we know what the impact of that would be? Although, of course, there are very good studies, especially in Portugal, on what might happen if you decriminalize. And in Portugal, consumption, for example, of heroin, which was particularly problematic in the 1980s, went down markedly. And they shifted the resources from criminalizing and putting it in the criminal sector into medicalizing. However, Nutt's approach is very, very interesting because he is suggesting basically, and the really interesting thing for any of us living in the United Kingdom is that some of the drugs that appear to be much less harmful, not least ecstasy and LSD and mushrooms for that matter, are actually class A drugs, and they carry particularly severe penalties, not only for possession, but especially for dealing as well. And therefore, we have an obvious mismatch between the criteria whereby the drugs are regarded within the criminal justice sector and the way in which we understand the nature of the potential harms of these drugs. It's a very powerful piece of work. Now, what emerges from this is, as I was saying, the mismatch between evidence and policy. And I'm very interested in the social implications of that. A lot of people between the ages of 18 and 24 are indeed, increasingly actually over 60s as well, for that matter, engaged with recreational drug use. And yet the penalties for doing so, at least on paper, are particularly severe. And yet the harms are often not as great as they appear to be if you think of the sentencing policy. So here we have some of the complexities of changing policy. You could bring a social scientist to this. We've already brought David Nutt into it, and we can start to talk about the social impact of criminalizing drugs that don't appear to be particularly harmful. But there are always risks. There's political costs vis-a-vis public opinion, and therefore politicians will always be second-guessing public opinion. We'll have some vested interests against change. One imagines the alcohol lobby for a start. And here we have, for me, I think, as a social scientist, a classic issue of problem containment rather than solution. Everybody seems to recognize, right from the very top of the UK politics down to police chiefs, down to social scientists, down to everyone dealing basically with alcohol and addictions, that the war on drugs doesn't work. I think it's hard to find a counter argument to that. And yet what we have here is problem containment rather than the solution. Although, of course, the containment is in form a political solution in itself. In other words, we know it doesn't work, but we're not going there because basically it's too risky politically to be able to engage in this. I think it's a very nice, interesting example of the way that quite often we have a mass of evidence which should suggest a particular direction of policy travel, and yet the ability to ignore it and contain it as a political solution by doing nothing is in fact a very powerful political decision in itself. Very briefly, David Nutt gave a nice account of the discussion he was having with a member of parliament, a member of the UK legislature, who said to David Nutt, who the lead author of the piece of work, you can't compare harms from a legal activity with an illegal one. And Nutt said, why not? And the politician said, because one's illegal. And Nutt said, but why is it illegal? And the MP said, because it's harmful. To which David Nutt said, don't we need to compare harms to determine if it should be illegal? To which the politician said, you can't compare harms from a legal activity with an illegal one. So we go around this circuitous inability to actually really engage with the research, because the policy framing of the research is we can't go there. Why can't we go there? Because we set the terms of the debate. Whereas the obvious thing to do is indeed compare harms to determine if it should be illegal. Okay, the final session I want to look at, our section here, is some reflections on my engagement as a social scientist in a multidisciplinary health technologies project. I could say projects because I've been involved in a few over the year, but I'm going to focus particularly on the one I'm engaged with at the moment. I want to start with the background on the policy issue and the perceived policy problem that we have here, and then I'll go on to basically what's happening now in terms of the current project and what it's like to work across disciplines, which involve, for example, different engineers, but also people from rehabilitative medicine and so on and so forth. So the policy problem in a nutshell is that the United Kingdom has got itself in quite a bit of difficulty here. The United Kingdom has an adult social care problem described as beyond crisis and a national scandal. And that's by a cross-political party parliamentary report, to which I've given you a reference there. It's a very interesting document, taking evidence from all sides, and it's made up of lots of different politicians from different persuasions, and they all agree that the adult social care problem in Britain is beyond crisis. It's a national scandal. We have extremely poor levels in many cases of adult social care. The provision is particularly not basically useful for the kind of flourishing of people's lives as they get older. Now, my argument would be that some of this is predicated basically on assumptions around how this would be dealt with going back about 15 years. We have to go back 30 years when the actual adult social care problem was highlighted in the UK by the Audit Commission, saying, unless we tackle this, this is not going to go away and will become a real issue. So back in 2006, the Audit Commission again said, you know, there's a tantalizing possibility here that some of these technologies which are being developed could start to deal with some of the crisis of social care. And the United Kingdom really went for this in a remarkable scale, quite unprecedented, but also not replicated anywhere else on the globe. So the United Kingdom became the world leader in using these types of technologies, often in cases of being a substitute for human social care. In other words, we can reuse forms of surveillance technologies, remote care technologies, which we can then use to solve whatever that might mean, the adult social care problem. Now, both on efficacy, quality of life, interoperability, multiple modalities, cost savings, unintended consequences, isolation, for example, scalability of uptake, all of this has been seriously misjudged. And I've written a paper on this in 2020, the reference there if you want to read it further. But at the same time, there's been no plan B put in place. So we've ended up in a situation where the UK put its eggs very strongly in one particular basket, if that metaphor can translate, in order to deal with a long-running problem of adult social care. It has not worked out as intended by any means, and therefore, in fact, it's exacerbated the adult social care problem, which is chronically and systematically underfunded. So we've got a real problem here. And the problem is basically, how do we deal with the social care problem when we don't appear to have been able to deal with it around the use of these technologies? Now, this was recognized early on, this idea of UK policy exceptionalism. So it's not just COVID where we do this, we also do it on care technologies as well. Jeanette Pauls and Dick Willems argued way back a decade ago, the dubious status of promises and the unpredictable processes of domestication of technologies that are so hard to trap with standard research methods make implementing these technologies, this whole telecare program, on a large scale and top-down basis, as is done in the UK, a hazardous investment. And that pretty much puts it in a nutshell. In other words, what was happening in the UK was we're introducing technologies which require a socio-technical understanding, and yet we are only using a hard sciences, much more technical approach in terms of the use of a research paradigm. In other words, we're going to use a randomized controlled trial for something in which you really need to understand how users interact with technologies, a socio-technical approach, as opposed to something you're going to get from an RCT. And basically, the specific hazards was a very limited research on how users actually interact with these technologies and how the benefits, keeping people in their own homes with technological gizmos, outweigh the potential costs, isolation, non-use of technologies, their time-limited utility as the circumstances of users change, especially, for example, if they have dementia. And also often found in the research that was carried out with users, the interoperability in cases of multiple morbidities. In other words, these technologies didn't deal with anything involving complexity. They were quite good with very single issues, but a lot of people who had some issues also had others. They had multiple morbidities. So the point I'm making here is that we did a number of evaluations involving qualitative research by social scientists, but they were always reactive. They were never actually engaged, embedded in any of the research at the outset of the technologies themselves. So there was a triumph, a kind of technological imperialism, if you like, which said the technologists will set the agenda, very much pushed also by the technology industry. And once all these technologies were put in place, then the social scientists and the qualitative researchers were let loose. And what they discovered was, in many cases, they didn't work very well, or people with multiple morbidities were unable to get them to operate together, or they ended up in people's drawers in their bedrooms, or they ended up in car boot sales or eBay, or various other places. In other words, they just simply didn't get used. So there needs to be an understanding of better experiences of different users. There may be end users, but also carers, practitioners who interpret data generated by these technologies. It was almost a triumph of a very technological approach, which then at the same time tended to sideline what we really needed to know was, do they work in practice? So this is summed up by a very nice paper by Trish Greenhalgh and others, the organizing vision for these technologies for telehealth and telecare, a discourse analysis published in the British Medical Journal, in which she was looking at the different ways in which discourses emerge in the various documents they were doing. So they looked at a lot of journals, they looked at policy documents to find out the different ways in which people looked at these. And we can see on the left-hand column here that kind of approach of technologists, what they've deemed to be the modernist approach. They talk about efficiency, cost effectiveness, rationality, technological progress. They use RCTs. They're looking for researchers looking for effect sizes, hospital admission rates, assumed characteristics, smart, reliable, and seamless. And then on the right-hand column, we have what they deem to be a more humanist approach, which often would be informed by more interpretivist research from the social science tradition, in which they're looking not so much at efficiency, cost effectiveness, and technological process, but experiences, relationships, reciprocities. How do these things actually work? How do people engage with the technologies? They use ethnography, they use interviews. They try to understand the individual's perspective. The research evidence is based on the experience of using and often actually the non-use of these technologies. And then some of the assumed characteristics that emerge from the social science qualitative research is problems with getting operability, potentially constraining. In other words, basically, they set up passive monitors, which means you can't really move around or live your life the way you might have lived it before because you're now being monitored because you're using surveillance systems. So these are very interesting. It's a very interesting discourse analysis of the kind of language that gets used from one research tradition and the kind of language that emerges when we use another research tradition. And they really don't sit easily together, because it suggests there's a degree of complexity here which needs to be dealt with. So what happened with the research in remote care technologies is that an RCT was set up, the largest anywhere in the world at that particular time. We had a randomized controlled trial, despite many of us basically saying, I'm not sure that's going to be the most effective way of doing this. And we can see basically that the Sorry, I'm just reading something in the chat function here, which I'm now going to get rid of. That's fine. The findings basically, I'm going to go back to the previous slide now. I'm trying to get rid of the chat function. Got it. Okay. So we can see here that the Parliamentary Office for Science and Technology has summed up basically the results of the trial were that there was no statistically significant reduction in health or social care use between the control group and the non-control group. And these was all published. It's a very large study, the largest randomized control trial anywhere in the world on this particular topic, and headlined findings of reductions in accident and emergency visits, selective admissions, and costs were not found to be statistically significant. Okay, we can. So, and I have a problem with my machine jamming and it won't move on. There we go. Also, on the questions for potentially for quality of life, to say telehealth should not be introduced with the aim of improving quality of life or psychological outcomes. Now, here's the important bit in terms of some of the politics of research, basically. Here's the United Kingdom Prime Minister, David Cameron, at a global pharmaceutical and biotechnology conference. He said, we've trialed it. That's true. It's been a huge success. That's not true. And now we're on a drive to roll this out nationwide. And this is not just a good healthcare story. It's going to put us miles ahead of other countries commercially too. Okay, so we have a problem here. And we can start to see we've got a framing here. We have a lot of research evidence. And this is not just an inconvenient truth from the social sciences. This is the use of a randomized control trial. The randomized control trial basically says there's no evidence that this is actually going to work on scale. And indeed, some of the claims about improving quality of life don't appear to be relevant either. And yet we have a political framing here, which says we've trialed it. It's been a huge success. And now we're on a drive to roll this out nationwide. And what happened, of course, as Trish Greenhalgh points out in an article in the British Medical Journal, is the Department of Health cherry-picked from the raw data before the trial had finished recruiting in such a way it could support the claims which the politicians were then able to use in their framing of how these technologies might be a useful intervention. It reminds me of something I came across a couple of years ago. Come up with a new idea, convince people it's good, the new idea is adopted, and the missing bit would be check whether or not it actually works. And that's the bit that gets missed out in the policy framing. So we need to have an understanding of research across disciplines and the consistent weakness of policy interventions. These technologies have not worked the way we expected. And also we haven't engaged the public, and therefore we have a democratic deficit in engagement over policy decisions. The ethical and demographic deficit, which has arisen due to proliferation and research and development of advanced care technologies, that's not been accompanied by sufficient consideration of their social context. Okay, so fast forward to the present day. The United Kingdom research and innovation, research funding is now moving rapidly in the shape of a focus on health technologies, involving social sciences as well as technologists and engineers. There's been a significant shift away from funding of the humanities. There's been a significant shift to what I'll call applied social scientists. It's a kind of model which we saw within the European Union Horizon 2020 model. It is nominally, in that case, more multidisciplinary because we're bringing the social sciences into projects that have traditionally been those reserved for engineers, for example. It happened in some cases before, but it's pushed the idea of trying to get working across boundaries, a multidisciplinary approach. And it's a shift of funding, basically, often away from the humanities, and we can see with the direction of this towards funding health and social care technologies. So what happened here was the United Kingdom Research and Innovation has basically funded sandpits. Sandpits are those where you get together some people and they spend a great deal of time, very intensively, I have to say, in coming up with a research project, and then they basically fund a couple of years in the first instance with the expectation it will go much longer than that for a proof of concept, or what social scientists might call a feasibility study. And in this case, the particular sandpit I was involved with self-management of health technologies, or health technologies that allow the individual to self-manage their condition. So there were over 300 applicants for this, from which we ended up with 20, what I'll call hard sciences, 3 from psychological sciences and 3 social scientists. So we can see already it's multidisciplinary, but it's heavily weighted to the hard sciences. So basically these people coming from a medical tradition or engineering tradition, effectively, with some social scientists basically put into the mix. I have to say that within the sandpit itself, the idea where these people all get together and discuss and form ideas and brainstorm around various issues, the format exhibited a considerable bias towards the hard sciences. Now, when I say bias, I'm not suggesting it's deliberate. That might be quite unconscious. But in terms of the format, the time slots for discussion, the kind of language being used, we had a very strong bias towards the idea of the kind of issues, the kind of approach that's taken by the hard sciences. And indeed, basically, I think the social scientists found it rather hard to try and get into this whole discussion because the nature of the way it was set up certainly wasn't set up for social scientists and the kind of areas in which we would think about engaging. By definition, social scientists will be part of a larger hard sciences grouping, but where they integrated or attached. Is this really multidisciplinary? So I find this an interesting question for a start. If you're going to talk about it being multidisciplinary, then you're going to have space to be able to have an understanding of different people's views of the world, their approaches, their kind of understandings of research method. But in fact, what we had here tend to be more the attachment of some social scientists onto a project which was dominated by the hard sciences. And so what I want to discuss here is something in this particular project, this particular sandpit, which was looking at the self-management health technologies and devising new self-managing health technologies that users could check their own conditions, that would alert them to conditions. They could then do something about that in terms of managing their own conditions. So the policy framing, and the one that's strongly understood by the engineers in the project, is basically this is about self-management of health. And there's a strong bias. Again, that may be unconscious bias. I'm not suggesting it's a deliberate way in which they want to buy into this. But basically, the drivers for this will be around policy failure and social care, technology-based solutions. So we have to think about doing something. So we're framing it, but the language that we're using is new, smart, easy, better. And what's really interesting talking to colleagues on the project is how much basically they haven't given a great deal of critical reflection on whether or not these self-managed technologies are necessarily a good thing. Indeed, actually, the way in which the language they're using frames these technologies, and indeed, for example, some of the questions that they're asking about how these technologies might be employed will suggest quite a strong buy-in to the idea that self-management of health using technologies is a good thing and will be a positive development in the future. And much of the politics of framing around this, again, is about inclusivity. If you talk to government policymakers, they talk about this idea of self-management will make it a more inclusive society. Now, here's some critical analysis on this that social scientists might want to ask questions about. And I'm going to start off with the idea that I'm not saying that self-managed care is going to not be a good thing or will be detrimental. I don't know that because we haven't done the research yet. So what I'm saying is that the policy framing is suggesting implicitly that this will be a good thing. This is exactly what happened with all the research around telecare and telehealth that we had over the last 15 years. It set it up as a priori. This will be a good policy, which will be advantageous for people. And therefore, a critical analysis at this stage would basically start to ask some questions, not least given what's happened over the last 15 years. Is this self-management of health actually really about the state disengaging from health and social care? Is it a wider disengagement from the idea of the state being engaged with a welfare state, which we've had in the post-war period? That would be something a political scientist would start to wonder about, or a social policy person would start to say, does self-management actually really liberate and empower people, or does it mean the state can then disengage and say, now you have to look after your own circumstances? It assumes that we will have active, engaged, participating citizens, because they're going to have to be able to use these technologies to be able to self-manage. But in fact, this new smart, easy, better language that's often used in the policy framing might, in case of a number of service users, especially those that are more marginalized in society, be new, but also complex and very challenging. It's quite fascinating doing work with service users, how few service users in the more marginalized communities have had access to email or even smartphones or even simple technologies that the rest of us might take for granted. So instead of being inclusive, it's actually potentially, and I can say potentially again because we haven't done the research yet, which is why this idea of prejudging it with that kind of policy framing is interesting, is potentially marginalizing unless users are active, engaged, and participating. And if you don't buy in and you're not active, engaged, and participating, then do you become further marginalized in a world which is moving towards the self-management of health conditions? That for me would be an interesting question to start thinking about. And it's not a question that colleagues so far on the project are really engaging with in a way that they're talking about the potential for self-management of health. It may have wonderful potential, I don't know that, but I am asking for some critical questions to be raised at this stage about what would some of the wider implications of this be. The sandpit process we're engaged in, this way of getting people to form a research project, there's a general feeling in the sandpit of some of the other disciplines not quite knowing what to do with the social scientists. Some of us became almost, well, certainly interesting in terms of a very limited exploration of what social scientists might be able to offer, despite the fact that the lack of social science inclusion in the early stages had proved to be so problematic with these technologies. One of the proposals in the sandpit coming forward for a research proposal did not have any social science involvement on the team, in which the qualitative data analysis would be presumed to be conducted by machine reading. That's a very interesting approach, but any social scientist will probably tell you someone has to set up the algorithm within the machine when it comes to read it, and therefore actually the interpretation is being set by the engineers or the other disciplines, and they're not being set by a social scientist. I find this fascinating about the way we just think we can do things using technologies without actually engaging in the more qualitative social science approach. The format of the sandpit itself was based quite strongly on hard sciences reporting rather than social science development of argument. I'm not suggesting for a second that the hard sciences don't actually engage in argument, but they have a particular way of reporting that argument. And all the social scientists basically felt there's no space for us to be able to actually engage in a more contextual discussion of socio-technical issues. I finally challenged this from the floor of the sandpit, and we ended up with substantially more time to do final presentations than were originally scheduled, because I said, actually, you're asking social scientists to be involved, but you're not actually engaging with what social scientists require to be able to engage in this multidisciplinary process. There is a kind of technological determinism at work here, not just in terms of some of the questions being asked or some of the assumptions being made about these technologies, but also just in the whole way in which the sandpit itself is being conducted. Our proposal was worked up, we rehearsed it extremely well, and we had a very last minute, by which I mean almost midnight minute, before the day of the presentation, reshaping of the proposal, in which much of the social scientist approach was actually removed from the final presentation. I found this extremely frustrating at the time, and I think in retrospect, it was possibly the right decision. And I think what was happening here was a second guessing about just how far the funders were prepared to take a radical approach to the idea of a multidisciplinary presentation. And I think what we ended up with was a very strongly engineering focused technical approach to solving a particular problem. In other words, we had a problem we wanted to solve. We had a very technical engineering approach to how we were going to solve it. And we had a section in there on how we would try and engage at an earlier stage service users or the likely service users of these particular technologies. But that's pretty safe stuff. It's pretty tame in some ways. And much as I might have objected at the time, I think there was an understanding that the funders would be looking for something fairly predictable, fairly mainstream, and therefore the social science approach had to fit within that rather than actually start to throw up too many radical ideas. I found this a very interesting, at the time frustrating, and in retrospect, probably actually sensible approach that we took. So what helped gain the research award? Well, we got awarded quite substantial research funding in the first instance, and it will probably develop long after that as well. And here I'm going to go back to precisely what helped in the original slides I was looking at between health and social care working together. And that is actually a personal willingness to interact with group members. And I'm going back again, see the previous slides on working between health and social care. It comes down to a willingness for people to engage, and not everybody is willing to engage across boundaries. So probably, and this might not seem a terribly scientific or highfalutin or complex way of describing an outcome, but actually the personal willingness and the personal qualities to interact as a group members were crucial to this. In other words, instead of a top-down approach saying, let's just bring together all the disciplines, the way this worked within the sandpit was a number of us thought we could work together because we seem actually people who are willing to engage and willing to bounce ideas, and we're not going in with too much prejudice in terms of our disciplines. So the absence of egos, the willingness to listen, and I have to say that wasn't always obvious across other aspects of the sandpit. And the integration of the social and science element, the key to this was to explore technology failures in terms of the absence of socio-technical understanding and approach to past projects to non-social scientists. So my approach to this whole project in the sandpit was to lay out basically that you engineers are doing some really fascinating, brilliant work here. And you've been working on all these various types of technologies for the last 15 years. And yet the adoption of these technologies has been low, and the adherence to using these technologies has been particularly low. And I can help explain this to you because basically you're going to keep producing these products, these really interesting technological devices, and they're going to consistently keep failing unless you address this in terms of a socio-technical understanding. And that was immediately understood and adopted by the other team members. I have to say that wasn't necessarily always evident across other people participating in the sandpit. I think the social scientists felt we were getting pretty short shrift from some other people, but in this particular team, there was an immediate understanding that the social scientists were going to bring a crucial element to bear to unlock the reason that we've had such poor response and therefore a social care crisis in terms of the adoption of these technologies. And finally, we had a very strong sense that there would be no discipline performativity around language. In other words, make it plain, make it straightforward, make it simple as possible. Let's get rid of the discipline performativity around the idea of these are the phrases that we use. Let's try and explain it. Let's make it simple. That, I think, was quite an important understanding early on about the way in which we needed to find a way to engage and to explain things to each other and find the space for the different disciplines to be able to explain. Okay, so this project is now currently underway. We have regular contact. We have a lot of space for explanation. We have very regular contact, actually. We have debate. The research assistants are forming their own group for discussion on debate on a weekly basis. We have the calling out of biases. So I think basically some of the things we conducted from a very engineering perspective, and I immediately call it out, and we immediately talk about why I'm thinking that and how a social scientist might want to engage. There's no attempt to try and genericize the process, so we're now moving away from the idea of this is how research projects are undertaken. We're trying to explore this in a more bottom-up approach because we're now talking about a multidisciplinary approach. What will it require? There's evident presumptions around technologies as progress, and non-adopters are somehow problematic amongst some, not all, engineers, both in the sandpit, but also I think that's creeping into the group itself. There's some already unconscious bias in language and framing. So we're having a discussion around this. And it goes back to the previous slide about me saying, basically, self-management of health might not always be a good thing for some people. It might not be accessible to some people, and we want to be careful that we don't marginalize some groups in society even further than they are. We have a sense here, I think, that the funders know that social sciences are important, but don't quite know why. I hope that's not too spectacular a claim to make. And so we're really interested, the social scientists in this project, I'm the social scientist on this project, but also the health psychologist, which is strongly aligned to social sciences. We're interested to know what will happen if the inconvenient truths of the qualitative inquiry indicate that the technical design ought not to proceed. And I think basically what we've got here is we've brought social scientists in at the beginning of a new way of looking at developing a technology, something that hasn't happened in the past over the last 15 years. The social sciences have always been reactive to the technological design and then explained why it's not being adopted or why there's no adherence to it. And here we're bringing in the social scientists at the beginning. But what if our social science inquiry says, actually, we've now done quite a substantial amount of work with service users and service users' wider communities and networks of who they engage with. And it looks as if people don't want to actually self-manage their healthcare. If this is what we come up with, and yet the whole project is predicated on the idea we have to move towards the self-management of healthcare, how then does this inconvenient truth, as we might call it, sit with the other people in the group who have a strong interest in getting ahead and designing what they see as a very interesting and innovative way to solve some health problems? I think that's going to be an interesting discussion down the line at some point, because if you want to bring the social scientists in at the beginning, then it may be that we're going to make this a more complex development of the technologies, simply because we've done the groundwork instead of actually doing it after the event and discovering why these technologies don't work. So here's a summary. We need to be able to cross disciplines to get fuller understanding of policy implications. It's, I'm not suggesting for a second we don't. I think cross-disciplinary working is crucial to solving some of the problems we have at the moment. Glasgow is currently hosting COP26, the climate change conference. And if ever you needed a cross-disciplinary approach, it would be that. We need to understand, basically, to get a fuller understanding of policy implications. But it's not easy and it's not straightforward. And simple top-down approaches to just getting people to talk together and work together, it requires a lot of work and trust. We need to have a more open understanding of what constitutes validity and the rigor of social science methods. We need to be able to actually defend the corner of social sciences. I'm now talking as a social scientist, because time and again, I've come across the idea that social science methods are not accepted by some other disciplines. And that is really problematic if we want to get a more qualitative approach on the agenda. We need to acknowledge the essential role of social sciences in understanding users' experiences that cannot be tracked by standard research measures. This is the big failure to date of much of the technological approach to health technologies of the last 15 years. We need something beyond randomized control trials. We need to understand how users actually experience these technologies and build on the basis of that. In the absence of this, the waste of effort and finance will continue, as indeed will the crisis in social care, because we don't really have a plan B for this. So a lot of riding here on the idea of self-managed care to address the idea of the crisis in social care. And at the same time, it's going to be interesting to see how much the inconvenient truths, as we like to call them, within the social sciences might then come up against the idea of that much more kind of technologically focused idea of solutions to problems. Perhaps the greater obstacle thus, and I guess this is the point of the talk I'm giving today, perhaps the greater obstacle to be overcome is not the tension between research disciplines as such, but the politics of how research sits with policymaking, the marginalization of inconvenient positions, the performative politics of governments, very much in evidence for me at the moment, United Kingdom around COVID, the political use and abuse of research data, which we've seen here with the idea that they say, we've trialed it, it's been a huge success, and you think, actually it hasn't. You're just cherry picking the data to make it look that way, and the pervasive influence of political lobbying. So we need to overcome the tensions in disciplinary boundaries, because I think the wider picture here is that people with research integrity, regardless of what discipline they might belong to, can understand the bigger picture, which is together we need to challenge some of the politics of the way in which policymaking is being carried out. And at that point, I shall leave this for others to think about. Thanks for your time.